Hello, everyone. This is Don McAnelly with Rehmann Healthcare Management Advisors. I'm joined here today with Carmel Roberts. Carmel is the practice administrator with Valley OB-GYN in Saginaw, Michigan. Hello, Carmel. Great to have you here with us again.
Good morning, Don. It's always a pleasure.
Carmel, we're going to talk about something pretty timely today. Recently, we're having this conversation here. I think today's March 12th. Yesterday, President Biden signed the American Rescue Plan Act of 2021. What it's meant to be is it's meant to take the country past, the COVID virus, moving us into a post-pandemic environment. We're seeing more and more people get vaccinated. Certainly, there's a lot of people out there for a variety of reasons who haven't been vaccinated, but the numbers are going up. Still a lot of people testing positive, unfortunately, for the COVID virus. And, in the state of Michigan, as well as other parts of the country, there's been a number of deaths still contributed to COVID, but I think the numbers are going down a bit. Do you see it similarly, Carmel? Is that what you're feeling?
I think certainly from the patient aspect, as a frontline worker in practice, we were fortunate enough to, have the vast majority of our staff already fully vaccinated. So that was, I think, collectively a sigh of relief, just speaking from a staff standpoint, especially with our specialty. I think as a provider, they were for a year very fatigued in their own right, because you would feel awful if you had COVID and you gave it to a pregnant patient or someone who is older and more high risk. So that definitely has felt like we're getting more back to normal. From the patient side of things, I think that one's a little bit more of a mixed bag. We still there's the fatigue of, we still require everyone to wear a mask, and staff still wears a mask. So I think that it will remain to be seen, how long we have to keep that in place. That's, I think, going to be a struggle for everyone.
Mm-hmm.
But I think that getting back to normal, maybe. But it's a qualified maybe from me on that.
Yeah, Carmel, I think some of the getting back to normal is going to be something managing the finances in a medical practice. I know the American Rescue Plan contains some provisions, haven't seen them yet, that are supposed to kind of, help Obamacare and help people's, help people in their ability to access insurance coverage. But, I think we're going to see some issues right now. We've had a lot of people who've been out of work right now. Perhaps Selfpay AR could be increasing. We're still seeing the increasing use of high-deductible health plans. That's going to make an impact upon cash collection and cash flow within the practice. How are you guys dealing with that?
Absolutely. That's an excellent point, Don. We noticed going into the fourth quarter of last year, and it's a trend that has continued into the first quarter of this year, an increase of our self-pay patients. So usually we run anywhere from 2 to 3% that are self-pay, and that bumped up to as high as 7% at its peak, in fourth quarter.
Mm-hmm.
I think a lot of that had to do with the timing of unemployment benefits and, people fully being able to get back and restaff. But that has an impact. I think the other thing, that the double whammy effect of the timing of it, is that in the first quarter of any year for a medical practice, you mentioned at the beginning, the high pay deductible plans for everyone.
Mm-hmm.
Well, no one's met their deductible in the first quarter. So, if you're already struggling, or as a patient feeling a financial impact from COVID, and you've got a high deductible plan and you've already put off care for a little bit because of the pandemic, I think as a practice, we've had to be very careful with how we approach that with patients. You'd certainly never want to deny care based on somebody's ability to pay, but being able to tweeze out whether or not there really is an ability to pay, or you have a genuine situation where, compassion and sort of making exceptions to our rules are concerned. That is a challenge. What we try to do, and we've done this for a long time, And I think it's really served us well. It's not everyone's favorite appointment that they keep with us, but I think afterwards there's a benefit unquestionably from the patient standpoint. So for the last 7 years, if it's our OB patients, our pregnant patients, for those practices that don't have that specialty, that is a service that bills global, meaning we don't get to bill for it in almost 98% of the cases. We don't get to bill for it until the patient delivers or that pregnancy concludes. So there's a 9-month delay on that. And typically that is the first time in a young lady's life that they are going to really give their insurance coverage a workout. You know, they're going to have to meet their deductible. They're going to have to figure out what they have co-pays on, whether or not they have co-insurance. It all comes into it. It's usually about a $2,300 out of pocket to a patient by the time they pay for their lab work, any ultrasounds, if they're high risk and have to go to a specialist. That's our payment. That does not include the hospital's payment if they have a C-section or for the anesthesiologist or for the hospital services. So you kind of get the idea that there's a lot that goes into it on the financial end. And so for us, what we've done for a long time, and it helps very much in this situation that we were already set up for it, we have the patient sit down with someone from our billing department, and they do a financial consult. And we have pulled their insurance, spoken directly, you know, to their carrier based on their plan, and we have a written good faith estimate of what we feel their out-of-pocket expenses are going to be for our services, our part of it. So we will set them up on a payment plan. It's a sort of a dummy charge that we have, you know, coded in our system. And then when we go to bill the pregnancy, because we go first as soon as we get the delivery report, then all of the payments that they have made to us for the last 9 months get applied directly towards their deductible. So it doesn't matter what time of the year it is. So first of all, they have a 9-month head start. You know, they're not surprised. I can't think of anything worse than being home with a new baby and then all of the bills start to show up. Then you're going to get a $2,000 bill from us. You're going to get the bill from the hospital, the anesthesiology. So that's one effort that we've had to combat it. It's just being very upfront and specific with patients. You know, you give them the information. Everybody's financial situation is their own, and you work with them to find whatever the best options are for their circumstances. So we do a similar process with any of our surgeries. You know, surgeries are always a little bit different because, you know, that's the conclusion in any specialty to, you know, a lot of diagnostic testing. And by the time you take it to surgery, it's because you don't have another choice. Like really, someone's quality of life is significantly impaired. And again, you go back to the theme of high deductibles. It certainly falls within that wheelhouse. So we do the exact same thing. We sit them down, we let them know ahead of time, we work that out with them, if it's a payment plan or care credit, like financing, that type of thing. And we have someone on staff that's really, it's not a collection agency, but it's someone that's her job 40 hours a week is to go through, to take those calls. She's very skilled and adept at knowing what, you know, type of options they have out there. That way they're not being bounced around. And again, like no one wants to hear that you've got to spend $2,000 on something that, you know, isn't a luxury or a pampering or, you know, a perk or a vacation, something like that. But knowing it up front and being completely transparent about it has been very helpful. From an AR standpoint, if you have someone that just says, I can't pay that, I won't pay that, you know, even if you've exhausted all of your options, I think there you know that if you had provided the service or if we choose to provide the service, then you knew you were never going to collect that money after the fact anyway, or the chances are. So that was a very long wind up to it, but you really hit on something that has been integral to our whole approach. In December of last year, part of the last COVID relief package, the consolidated appropriations that President Trump signed in late in December, part of that was the no surprise billing provision that's been talked about for a long time, that hospitals now, they basically have to do the same thing that we've been doing for, 6+ years.
Carmel, this is really interesting stuff, because what we've been seeing with a lot of the clients that we work with is, patients delaying care. And this is an unfortunate side effect of what's going on. With all the pandemic, there's a subsect of our population who's, pretty anxious. I've heard of a lot of people don't even want to leave the house. And then there's a lot of us who are saying, I just want to get back to normal. It's been interesting over the past couple of weeks. We've seen some states, get rid of the mask mandates. Doesn't mean you can't wear a mask if you want to wear a mask. It's just they're not mandating the wearing of the masks. And so you're starting to see just society's changing a little bit. It's getting quite polarizing. That's concerning to a lot of our clients. But, it's interesting how this is impacting patient care. But, managing your practice is a significant part is around the patient care environment, but also it's managing your staff and managing your people. I'm interested in your thoughts on this, Carmel. There's been some provisions within the American Rescue Plan that continue kind of the premium payment to people who are on unemployment. There was also a provision in the bill that is going to remove from federal taxation, I think it's up to $10,000 worth of an unemployment benefit. I've got a lot of clients, and as a business person, it's concerning to see, what many are looking at this as being somewhat of a disincentive to work, that some people aren't really wanting to work. I see a lot of signs up there, help wanted, help needed. And a lot of clients I work with are struggling to find qualified candidates. And it's difficult when your unemployment agency is some of your principal competition. What are your thoughts on the staff that you're managing and keeping them motivated in this type of an environment?
You are throwing the hard balls this morning, Don. Political questions. We did have that struggle last year. We had some staff, like long-standing. We are very fortunate that we have a lot of longevity in our staff. We have 2 ladies in the office who have been with us for over 40 years. So we had a lot of longevity in our staff, and we had a few staff members who were slated to retire like later in 2020 or in 2021, and they decided to pull the trigger on that in COVID when we went into lockdown, because they just weren't sure. No one was sure of anything at that point. And, in a health facility where we needed to continue to see patients, they opted to basically sit it out. And that set off a cascade for us. And we did experience that where we could find people that maybe had been laid off from other places, or, for the various reasons they were in the job market. We went through 5 people, which is unheard of for us. Wow. And either they went back on unemployment, or they went to, when their old job got back up and running after the second round of the Paycheck Protection Act money. But you are not wrong in saying that, there was some element to it. I don't know how much, but some element that was definitely, that the money was a factor. Mm-hmm. When you pile that on to all of the at-home schooling that's still taking place, I think that's another factor to it. Mm-hmm. You just can't go to work during a pandemic and leave your kids, if they're at an elementary school age, to their own devices. That was the other challenge that we had. Once we did get people, and we were fortunate again, we had people that we were able to maintain, and they still showed up for work. But once we did get people, we had to really be creative and accommodating with them to allow for the extra, the outside work pressures that COVID brought to everyone's life. And that was, I think, being accommodating really paid off for us because we didn't have a lot of people that opted to, take the unemployment. But that is definitely a factor. I heard that a lot of places, that everybody makes a rational decision based on cost and money. I think most people do, or that if you're better off staying at home financially than you are going out at work, where you could face getting COVID or bringing it home to your family. I'm not sure personally that was the right approach for people. I think that the people who stayed in and locked themselves in, their perception of the level of risk was very high. That if they were going to go out, that they were going to get, and it took a toll on people mentally. It was the delaying of care. Like, we saw that in the delay of care. We had people, one of the things we faced last year, we had pregnant patients, sometimes they need to go to the ER.
Oh my.
And they were putting off going to the ER because they did not want to get COVID.
Wow.
Which, that's a worst case scenario with a pregnancy.
Right.
Or they were contemplating home birth. And, that's not to say that there aren't some situations where that can be safe, but they are truly few and far between. So we really had to double down on a lot of our reporting and develop reports, in our EMR that and get a workflow in place where we were watching to make sure for our OB and for some of our other patients, we identified who was high risk. And then based on that high risk criteria, we looked at their last appointment and any upcoming appointments to make sure that they did not have a gap in care. And that's something that we're still doing. I think that was actually, it will be something we continue to do post-COVID, which I think is just better care. But definitely there were so many facets to how that impacted it, both, as you point out, Don, on the employer front, just managing staff with it and keeping enough staff to the patient side of it with delaying care or making sure that you're not missing people, that we were reaching out and that we were able to provide care.
One of the most any manager will tell you one of the most valuable players on the baseball team is that utility player, that person that can play outfield and second base and can get off the, and pitch hit in the ninth inning for you. And, having a cross-trained staff, having those people that are cross-trained that can handle the front desk, that might be able to, help with the billing or might be able to help room patients and get them ready, is an extremely important asset to their practice. Carmel, I hear it from a lot of people I work with, developing a well cross-trained staff is something that they really focus on. And I think in this post-pandemic environment, when you're really struggling to keep people there, having those utility players has got to be invaluable to you.
Absolutely. You've got to know that your bench is wide and deep and that you can throw people in where they're needed. That's an excellent point. We did do a good deal of cross-training with our staff. To cut down on the amount of people and just to keep patients flowing, we had to get pretty creative, and we would not just the contactless. We've been doing like contactless or digital check-in for a long time as well. So again, that was an easy thing for us to pivot to. But when you are faced with staff shortages that you can't plan for, because all of a sudden they call and someone in their family's positive or they've had an exposure and they're out for 10 to 14 days in quarantine, that is very difficult to staff, and there's no way around it. You absolutely have to have cross-trained staff that can, you need to know what your contingency plan is, and you need to actively have one in place and think about it. We were able to pivot a lot. If we made sure we knew what things could be done at home. One of the things that we did is we revamped for periods of time, depending on staffing, we revamped how we did things. So when we got to a certain point with staffing, we knew that we needed to switch to a more centralized chart prep, that we had a stable of nurses, that they were going to go through and prep charts, and it was, you know, really divided out to them. And that on the day of, we had a plan for the care provider that was seeing that schedule of patients, you know, for how we were going to get their patients through. But it would have all been done behind the scenes ahead of time. There were some of those things that could be done remotely, even if they were just quarantining, so if that makes sense. So if they were sick, then obviously they were just out with it. But if they were just at home quarantining, then we utilized them. That was one of the things we pivoted to, and it worked well.
You know, Carmel, so much has happened in the years since this pandemic hit, and really, you know, we've been working on the cars on the fly. You know, practices have had to pivot so much to help continue to be successful. Thanks a lot for this discussion today. Appreciated your thoughts and insights in managing your practice in a post-pandemic environment. Appreciate that, Carmel.
Always a pleasure. Thank you, Don.